Anatomically, the mammary gland is a paired exocrine organ. It is, by definition, a heavily modified apocrine sweat gland that sits embedded entirely within the superficial fascia of the anterior chest wall. This schematic maps the clinical boundaries, vertically from the 2nd to 6th rib and outwards to the mid-axillary line. Divided into 4 quadrants, the upper lateral quadrant extends into the axillary tail of Spence, piercing the deep fascia directly into the axillary space. Because functional parenchyma tracks through this fascial opening, malignant growths can originate deep within the armpit. A physical breast examination restricted to the visible boundaries of the chest wall will entirely miss this deeper extension. Slicing the tissue into a sagittal cross-section allows us to reconstruct the organ's architecture from deep to superficial, beginning at the bare pectoral fascia over the muscle. Resting immediately superficial to this fascia is the retromammary space. This narrow layer contains loose connective tissue, but absolutely no fat. It acts as a sliding plane, granting the entire gland mobility over the rigid chest wall. Moving outward, this cross-sectional diagram details the stroma, the supportive framework of the breast. You can clearly identify these distinct fibrous septa, recognized as the suspensory ligaments of Cooper. These ligaments function as strict internal anchors. They tether the dermis of the overlying skin straight down to the deep pectoral fascia, bearing the weight of the tissue and maintaining the physical contour of the organ. Suspended within this fibrous scaffolding is the parenchyma. This is the functional mammary gland itself, categorized as a compound tubulo-alveolar gland and divided into 15 to 20 distinct lobes. Each lobe is essentially a cluster of alveoli designed to produce milk. Fluid drains from these deep alveolar clusters, traveling outward toward the surface through converging lactiferous ducts. Just before terminating at the surface, each lactiferous duct widens into a distinct dilation known as the lactiferous sinus, which operates as a temporary fluid reservoir immediately behind the nipple. On the surface anatomy, the pigmented skin encircling the nipple forms the areola. The outer margin of this area contains an abundance of modified sebaceous glands. During pregnancy and lactation, these swell into visible nodes called the tubercles of Montgomery, secreting an oily lipid to lubricate and protect the areolar skin. Because these ligaments are anchored to the dermis, the internal retraction creates distinct visible dimpling on the surface of the skin. The glandular tissue undergoes rapid, extensive hypertrophy during pregnancy and lactation. Supporting that metabolic demand requires a highly dense arterial network. This diagram illustrates the dual arterial supply lines that effectively split the perfusion of the breast into distinct medial and lateral territories. The medial half of the gland receives blood primarily from the perforating branches of the internal thoracic artery, a vessel originating from the subclavian artery deep in the chest. The lateral half is perfused by branches stemming directly from the axillary artery in the armpit, specifically the lateral thoracic, superior thoracic, and acromiothoracic branches. Venous drainage exactly mirrors these arterial supply lines. The deep veins first converge toward the areola, forming an anastomotic venous circle around the base of the nipple, before tracing back outward to empty into the axillary and posterior intercostal veins. Neurological control is supplied by the anterior and lateral cutaneous branches of the 2nd through 6th intercostal nerves, which deliver sensory input from the skin and autonomic signals to the local smooth muscle and blood vessels. These nerves, however, hold zero control over the actual secretion of milk. While innervation handles local blood flow and muscle contraction, lactation is entirely governed by hormones, primarily prolactin, released by the pituitary gland. This massive redundancy and vascular supply is required to support the metabolic spikes of pregnancy. Clinically, however, this identical network provides a highly efficient, high-volume pathway for malignant cells to achieve systemic circulation. In surgical oncology, mapping the vascular supply is secondary. The defining anatomical feature of the breast and the primary vector for metastases is its lymphatic drainage network. The tissue utilizes a bifurcated drainage system. The superficial lymphatic vessels drain the overlying skin, while the deep lymphatic vessels drain the active parenchyma, the areola, and the nipple. Deep drainage originates at a central collection hub positioned immediately deep to the areola, known as the subareolar plexus of Sappi. From this plexus, fluid routes outward following a rigid, asymmetric distribution. This map tracks the clinical standard for lymphatic flow, the 75-20-5 rule. Exactly 75% of all lymph from the breast drains laterally into the axillary nodes, primarily targeting the anterior or pectoral cluster. Once in the axilla, the lymph follows a sequential cascade. Fluid from the anterior and posterior groups flows into the central and lateral nodes, moves upward through the apical nodes, and eventually exits through the supracliticular nodes. 20% of the lymph avoids the axilla entirely. It flows medially toward the sternum, draining directly into the anterior thoracic or peristernal nodes. The final 5% travels deep into the chest wall, draining straight back into the posterior intercostal nodes positioned near the heads of the ribs. Breast carcinoma is a pathology of the lymphatic system. Because 3/4 of all interstitial fluid flows laterally, surgical staging relies entirely on tracing this exact anatomical roadmap. When searching for early metastatic spread, surgeons systematically target and biopsy the anterior axillary nodes first. Clinical anomalies in the breast trace directly back to the 6th week of intrauterine development. The complex architecture originates as a simple ectodermal thickening known as the mammary ridge, or the line of Schultz. The entire glandular structure initially forms as this continuous bilateral strip of tissue, extending vertically from the axilla straight down to the groin. As the fetus develops, the vast majority of this ectodermal ridge normally disappears. It persists only in a highly localized section of the thoracic region, establishing the isolated mammary kit. Developmental failures on this timeline create structural deficits. If the localized thoracic ridge fails to mature, it results in amastia, the complete absence of breast tissue, or athelia, the absence of the nipple. However, if the full embryonic ridge fails to regress, residual tissue is left behind along the original vertical track. This incomplete regression manifests as polymastia, the development of supernumerary breasts, or polythelia, extra nipples that present exclusively along the vestigial milk line. From its origins as a bilateral embryonic ridge, the mammary gland evolves into a hormonally driven, highly perfused exocrine organ. In the clinical setting, accurate diagnosis and surgical intervention require a precise mastery of its physical anchors in the superficial fascia and a strict mapping of its dominant axillary lymphatic pathways.